يا محمد احنا جاهزين سيدي. مساء الخير جميعا، الله يعطيكم العافية. نرحب فيكم في لقائنا الأسبوعي المتجدد مع محاضرات اللجنة العلمية. محاضرتنا في هذا الأسبوع إن شاء الله بعنوان Approach to Geriatric Fractures مع دكتور محمد علامات، طائر عظام في تيم الكسور المتقدمة في مركز تأهيل ملكي. دكتور محمد الله يعطيك العافية، تفضل سيدي.
الله يعافيك دكتور ناصر. السلام عليكم جميعا، مساء الخير شباب، يعطيكم الف عافيه. اليوم راح نحكي عن ابروش تو جيرياتريك هيب فراكشر. هذا الموضوع بصراحه له شجون، له كثير ديتيلز. اوكي، راح نحكي شوي عن الابيديميولوجي، الايكونوميك بيردن، البري اوبراتيف ايفالويشن، الاوبراتيف مانجمنت والتايمينج، البين مانجمنت، بلاد ترانسفيوجن، الانتي كواجوليشن، ديليريوم وريهابيليتيشن. اول شيء عندنا ريسنت ارتكل صحيح، يعني من اور ليترشر ان جوردن published تقريبا 6 or 7 months ago about the characteristics of elderly hip fracture patients in Jordan. هاي study عملوها في two university hospitals and two major government hospitals. عملت على 1268 مريض. More than half of them, 53% were female. The average age 75 years, and the trochanteric group of the geriatric hip fracture is 66%, and 7% have a prior contralateral hip fracture. الافريج تايم تقريبا من الادمشن للسيرجري was 3 days, والسيرجري done within 48 hours في تقريبا 56.7%. One third of those patients received blood transfusion. Average length of stay in the hospital was around 1 week. البوست اوبراتيف ثرومبومبوليك ايفنتس كانت تقريبا 2.4%. الري ادمشن within 1 month كان 10%. الريفيجن for the same surgery was 3%. المورتاليتي at 1 year in Jordan was 12.8%. هاي الديتيلز بصراحه الابيديميولوجيكال ديتيلز بتهمنا in management of this fracture to know what is the characteristic, what is the personality of geriatric hip fracture. Okay, how common is this problem, and how common the complication is, the complications are, and how is the percentage of mortality. The annual incidence of elderly hip fracture in Jordan تقريبا 96 per 100,000 individuals. 1 year mortality rate for hip fracture in Jordan is 12.8%. below طبعا بتشوف انه 21% in the United States mortality at 1 year and 23% in Europe. According to reports from the European Union, mortality related to low impact trauma hip fracture is greater than road traffic accidents and is equal to breast cancer patients, and the mean duration of hospitalization variable بس تقريبا around 8.6 days. Shorter stay may be associated with higher complications rate after discharge, so the patient should be managed well and admitted for adequate time to achieve adequate rehabilitation. What is the cost? Recent systematic review showed that hip fracture cost for the patient $43,000. Acute coronary syndrome causes $32,000 and ischemic stroke causes $34,000. Pre-operative management بهمنا كثير بالامرجنسي بالبري اوبراتيف ايفالويشن انه يكون عندنا predefined protocol universally agreed upon pathway. تمام. And this should be a co-management between the anesthesia, the emergency medicine, and the hospital internal medicine as a whole. احنا في عندنا كونسبت اللي هو fast track preoperative evaluation and optimization of the patient. So this needs a co-managed approach. ليش fast track preoperative evaluation? Because how to be achieved? This achieved by having a well-established protocols and the previous agreement with the emergency department to handle such patients. Okay, this is a bad experience for the patient. Okay, and the emergency stay should be limited to not more than 2 hours. So the maximum time in the emergency should be 2 hours. Or in general, the time the patient spent in the emergency when it is less than 2 hours, this is a good measure of how well is the system works. Now, what should we do in this part of assessment, of evaluation? In the fast track preoperative management, we should have a medical clearance. We should have a good pain control. We should have fluids and electrolyte management and coagulation management and the timing of surgery. We should have, let's see, a provisional idea about the time of surgery. The preoperative evaluation starts with taking good history, including the trauma mechanism, presence of any syncopal falling down, identifying the physical function of the patient, the level of activity, the social history, whether the patient is dependent or independent, who is taking care of the patient, what is his living conditions and situation, what kind of home he is in, what kind of toilet he have, and in addition to taking an adequate medical history and knowing the medications that the patient uses. Another thing is the physical examination. It's important to have a general look about the patient, all of his vital signs, looking for any signs of dehydration. Almost all of those fragile, elderly, all of them are in a dehydrated state, okay, and looking for hypothermia and doing the initial laboratory testing and start the therapy immediately in the emergency with infusion therapy substitution and warming if any hypothermia. The control parameter is the blood count, the temperature, central venous catheter, and important to estimation or sign of well-hydrated patient is the urine output. We should aim for a urine output of more than 100 cc per hour. Medical clearance. Now, موضوع الميديكال clearance, we should optimize the medical condition only if the measure lowers the risk of surgery. If the risk of surgery cannot be altered, surgery should be performed without any further delay. Because delaying surgery, if risk cannot be altered, will add an additional unnecessary risk on the patient. طيب, situation that need action and may delay the surgery. بصراحة few clearly defined situations اللي ممكن تعمل delay للسيرجري that can cause delay the surgery, and in these situations the patient will need additional preoperative preparation and medical stabilization. But any delay should not exceed 72 hours. Any delay of surgery for more than 72 hours will cause significant increase in complications. هسه الissues that يعني can delay the surgery either related to the mostly to the heart, okay, and the heart output, أو البرين, أو presence of active infection, أو presence of pulmonary issue. Okay. Regarding cardiac issues that may delay the surgery and need to be optimized is the heart failure, acute cardiac ischemia, unstable angina, severe hypotension, unclear systolic ejection heart murmur with examination which suggests aortic stenosis, brain issues such as acute stroke, any acute infection such as pneumonia or septicemia, severe chronic obstructive pulmonary disease, all these need optimization. On the other hand, في عندنا medical conditions that should not delay the surgery. These include the hyperglycemia, the hypertension, and presence of well-established COPD without should do avoidance of exacerbation with bronchodilators and hypothermia, because maintaining the patient core body temperature between 36 and 37.5 is the ideal goal, and this associated with the reduced infection rate and less perioperative complications. Dehydration is very important thing to take care of in those patients. As we said, most of those patients are dehydrated, so we should have good IV fluid support to prevent any cardiac dysfunction, and also this is necessary to prevent hypotension when anesthesia is given. عندنا some figures بتحكي عن يعني around 100 to 150 cc per hour of normal saline if there is no contraindication from a medical point of view. ليش موضوع الديهيدريشن is important؟ لاحظوا شباب عندنا بهذا الدياجرام on the left side we can see the blood pressure readings, the systolic and the diastolic in the preoperative period, and in the operation room you can see that after receiving anesthesia the patient will have a significant drop in the systolic blood pressure and in the diastolic blood pressure. So the patient should be well hydrated before the surgery. Basics: should stop most blood pressure medications, preoperative IV fluid hydration, avoid hypotension, and consider low dose beta blockers to prevent arrhythmia. One interesting بصراحة يعني piece of information about beta blockers في هاي الستدي اللي انعملت على 134,000 كيس تقريبا included in the study, there was a significant reduction in the risk of mortality in the first year following hip fracture surgery on those patients who are on with ongoing beta blocker therapy. Functional ability. How active is the patient? This is an important question that we should ask ourselves, because the functional ability reflect the impact and the severity of the comorbidities. So more severe comorbidity, this means a lower functional activity. هذا الشيء was يعني described in something called the metabolic equivalence. Okay, so metabolic equivalence, okay, is a coded number or a number according to the patient need for oxygen. One metabolic equivalent is the amount of oxygen consumed while sitting at rest, equals to 3.5 cc oxygen per kg per minute. هسه هذا الدياجرام this is taken from a Western literature might not apply يعني fully in our society, okay, but when you have a patient with walking, let's say, climbing stairs, okay, or a number of metabolic equivalents of 4 or more, this means that this patient most likely will not have, he's not having a significant cardiorespiratory disease, and there is a low risk from his surgery. Again, medications to stop preoperatively, ACE inhibitors, blood pressure medications except for the non-rate, blood pressure medications, the non-rate controlling medications. The rate controlling medications such as the beta blocker we should keep giving to the patient. NSAIDs should be stopped. Anticoagulants should be stopped, clopidogrel, aspirin, and warfarin. And we will talk about these anticoagulants in details after a few slides. موضوع الروتين cardiac evaluation, preoperative cardiac testing most likely will not improve the outcome and will not change the management. Okay, so this is not necessary routinely. Okay, so preoperative evaluation is by cardiac surgeon is rarely indicated from a scientific wise and from scientific point of view. Timely surgery, rapid as soon as possible. Okay, surgery and avoidance of complication should be the primary goal. Another thing that might be done routinely, which is the echocardiography. Echocardiography preoperatively is not required in most patients. It's only required in very limited and very specific number of conditions. It is indicated when we need to assess the left ventricular function when the patient have an increasing or unexplained dyspnea and he is known or suspected heart failure or heart disease. And if there is a significant valve stenosis or regurgitation and no echo in the last 12 months, especially if the symptoms have increased. So for stable conditions, we don't need echo. Any significant murmur without prior echo should have echo. Patient with non-cardiomyopathy or significant valvular lesions or significant pulmonary hypertension and last echo more than 12 months ago with a clinical suspicion of disease or progression. موضوع الconsults sometimes maybe might be overdone. بصراحة I brought an example from the University of California, San Francisco hip fracture protocol. You can notice that if the answer is yes for this question, okay, we should go for medical service consult. For the cardiac conditions, only if we have decompensated heart failure, unstable angina, or new onset chest pain, new onset arrhythmia, non-severe valvular disease, new systolic murmur, and pulmonary, we need consults only if there is bronchospasm in examination or increase O2 needed to maintain baseline oxygen saturation. Neuro consult needed when there is a new onset mental status change or a focal neurological deficit. Regarding the labs, not any change in the lab will need a medical consult. Okay, serum creatinine only if the increase is by 50% from the baseline or more, or there is decreasing glomerular filtration rate by 25%. Only hemoglobin less than 8 might need a consult. And regarding the endocrine consults, it is indicated in patient with DKA, blood glucose more than 400, and patient with insulin pump. And regarding the medications, if the patient is on anticoagulants and antithrombotics or INR more than 1.5 or platelets less than 100, we might go for a medical service consult. Just to summarize I quoted again from the same protocol of California, what is done in the emergency after having an history and physical examination. They go for radiographs. They do 4 radiographs: low AP of the pelvis, AP of the affected hip, AP and lateral of the affected femur. MRI is the second choice if high suspicion and no clear fracture line. MRI, not CT scan. And they mentioned CT scan if MRI is not available. Regarding the labs, routinely they do CBC, chemistry, coagulation profile, and vitamin D, and type and cross match for 2 units of packed RBCs, type and cross match for 2 units of fresh frozen plasma if the patient is on warfarin. Chest X-ray is indicated if the history of heart or lung problems or there is new symptoms, and ECG is indicated if history of heart or lung problems or new symptoms. Pain control for all patients, anticoagulation managements, and consults for the geriatric care and the medical care accordingly. And an important thing صراحة شباب هاي النقطة maybe missed many times, which is delirium and agitation management and assessment. We should assess those patients. We'll talk about this point in details at the end of the slides, okay? But it's the evaluation of this issue, the delirium, should be started in the emergency department. Okay. Now, sometimes we are faced with challenging scenarios. What if my patient is on anticoagulation therapy? Okay. If the patient is on aspirin, we can continue at all those, or we can stop aspirin, and this should not delay the surgery by any means. But in regard to warfarin, we should hold warfarin and give vitamin K, 5 milligram per immediately and as soon as possible. And we should do a type and cross match for 2 units fresh frozen plasma. Our goal for INR is 1.5 or less for the surgery. If the type of anesthesia to be used is neuroaxial, spinal, or epidural, our target INR should be 1.3 or less. The INR is checked 12 hours after giving vitamin K. And they mentioned that we can proceed with surgery if INR 1.8 or less, and the patient can get fresh frozen plasma on the way to the OR. And the patient will receive GETA, general anesthesia, general endotracheal tube anesthesia. This indicates how they are careful about and insisting about having an early surgery as possible. Other thing is the Plavix and these other types of coagulant. This medication to be continued in any acute coronary syndrome, treated medically or with a stent within last 12 months, and continue of drug-eluting stents in the last 6 months in non-acute coronary syndrome, and continue of bare metal stent within the last 1 month in non-acute coronary syndrome, and no need to delay the surgery, and patient will receive general anesthesia. Usually, the issue of coagulation is more related to the anesthesia rather than the risk of bleeding. The Lovenox, Clexane hold before surgery, dabigatran, rivaroxaban, apixaban, all these should be stopped and recorded. The time when these medications were stopped should be recorded in a clear way, in a clear manner. Clearance of these medication highly depending on the renal function. But in general, in hip fracture surgery with general anesthesia only can be undertaken 24 hours after last dose for all medication in patient with a normal renal function. Regarding the dabigatran, apixaban, and high risk of bleeding, we should wait for 48 hours. Risk and benefit should be discussed between the different members of the managing team. Now, the timing of the surgery. If I have a medically stable patient, delay of more than 48 hours for hip fracture significantly increase short-term and 1 year mortality, and delay of more than 48 hours for hip fracture surgery increase 30-day all-cause mortality by 41% and 1 year all-cause mortality by 32%. Frail elderly should be treated as a priority and have surgery within 24 to 48 hours. In unstable patients, on the other hand, timing of surgery in those patients is controversial. but medically unstable conditions that have to be improved, as we said, include the acute cardiac conditions, the acute renal insufficiency, pneumonia, severe asthma, stabilization of patients, surgery when medically optimized, or palliative care if appropriate. This is just to summarize, okay, what we quoted from an article. This is a diagram shows that when there is no severe comorbidities and the functional status is good, we should go for early surgery. But if the functional state is low and relevant comorbidities, and we can optimize the patient and decrease the risk, okay, we can delay surgery to improve the medical condition first. But if there is no chance for optimization that lower risk of surgery, we should go for surgery as soon as possible with careful monitoring and perioperative care as needed. ليش موضوع time of surgery in those patients ليش موضوع time of surgery in those patients is crucial and important. هاي الstudy okay studying the relationship between the time of surgery and the complications. There was a decrease in the rate of pneumonia and in the rate of pressure sores, okay, when there is an early surgery with no change on the risk of DVT and PE. For the same study again regarding the mortality, the short term, the mid term, and the long term mortality rate is decreased with early surgery. After optimization of the patient, going for surgery. Anesthesia. Either the patient can go for spinal anesthesia or general anesthesia. Spinal anesthesia has the advantage of reduced risk of delirium, of thromboembolic events, pneumonia, and bleeding complications. Okay, and anticoagulation history may preclude safe use of spinal anesthesia زي ما حكينا when the INR is high, okay, more than 1.3, the spinal anesthesia is not possible. So we might go for another method of anesthesia, which is general anesthesia. What the advantage of general anesthesia is that it provides a better control of the hemodynamics, the blood pressure, and the other hemodynamic parameters. And the general anesthesia is technically easier, and you don't need the patient cooperation and to be in a certain position and multiple trials, okay? So it is technically easier. What again to be done with the anesthesia? Two things, tranexamic acids, and antibiotics, okay. In reality, there is a strong recommendation by the last version of the American Academy Orthopedic Surgeon Guidelines regarding management of geriatric hip fracture. They strongly recommend use of tranexamic acid to reduce blood loss and blood transfusion in patients with hip fracture in a rate of 10 milligram per kg IV at the beginning and the end of the case. And specific concerns for contraindication to be discussed between the attendings. And the standard preoperative antibiotics are a weight-based dose of cefazolin. And if the patient is allergic to cephalosporin, we can go with vancomycin. And in penicillin allergic patients, we can also go with vancomycin. After going with the anesthesia, we go with the issue of surgical intervention. As we said, surgical intervention as early as possible, adapted anesthesia, and adapted surgical procedures. What are the conditions or the point that we should take care of in the surgical procedure? It should be single shot surgery, minimally invasive surgery as possible, and optimal implant for osteoporotic bone, and allow immediate weight bearing as possible. Regarding the geriatric hip fracture, you can classify them in a broad terms into the intertrochanteric fracture, the intercapsular neck fractures, and the subtrochanteric fracture. The vast majority of these is the intertrochanteric fractures. Intertrochanteric fractures are classified either into a stable and unstable. And this classification helps determine the best implant. The issue of stability means that the fracture will not displace when physiologically loaded after fixation. Now, in order to assess and determine the stability in intertrochanteric fracture, we need to evaluate the bone remaining in the lateral and the medial femur. As know, the medial side, this is the medial side of the intertrochanteric area, will resist any varus collapse, and the lateral side of the bone will prevent any medialization of the shaft by providing adequate lateral support when the fracture is loaded. Comminution of the greater trochanter and the direction of the fracture also adds to the assessment of stability. So when regarding the direction of fracture, you know, there is an entity we'll talk about after a while, which is the reverse oblique fracture, where the fracture shape is in this direction, and this will cause favors a shearing movement when the fracture is loaded. This adds to the issue of instability. The AO classification, you know that the femur is referred to as number 3 as a bone. The proximal area of the femur is referred to as 1, a number. And after that, we have the A1 fractures, okay, which is the stable category, where A11 is only the greater trochanter is involved, A12 when there's simple fracture line, and A13 when there is a simple fracture line but with a lesser trochanter avulsion. The A2 and the A3 are the unstable part of the intertrochanteric fracture. In A22, there is a thin lateral wall, less than 20.5 millimeter, and as you most of you know, that it's measured 3 centimeter from the innominate process. This is the innominate process, the greater trochanter, 3 centimeter, and in line with the axis of the neck toward the fracture line. This area, when it's less than 20.5, it goes with A22 classification according to the AO, and A23 when there's a multifragmentary fracture. A3 relates to the direction of the fracture line with a reverse obliquity. You can imagine that when we are loading this area, when the load is transferred from the axial to the appendicular skeleton, or from the pelvis, okay, to the limb, okay, there will be shearing, two surfaces moving against each other instead of having lateral, resistance or counteraction from the lateral wall of the proximal femur. Now, at the beginning, stable intertrochanteric hip fracture. What should I use? A DHS, sliding hip medullary implant. The sliding hip screw is an extramedullary fixation, and the IM implant, intramedullary, what we refer to as proximal femur nail or sphenomedullary nail, is the intramedullary type of fixation. According to the American Academy of Orthopedic Surgeons, their last version, the cephalomedullary device in stable intertrochanteric fracture, okay, use of either sliding hip screw or cephalomedullary device is recommended. And so you can choose from either one you are familiar with. You spend less time doing the surgery, okay? So you can choose either the sliding hip screw or the cephalomedullary device. The strength of recommendation is strong. And the National Institute for Health and Care Excellence, they recommend using extramedullary implant, such as sliding hip screw, in preference to an intramedullary nail in people with a trochanteric fracture above and include the lesser trochanter, except for the reverse oblique fracture. Now, sliding hip screw and side plate is reliable and inexpensive and widely available. What are the measures to take in order to optimize this fixation method, the sliding, the DHS, in order to decrease the rate of complication? An important measure is the tip apex distance, which is the summation between of the distance on the AP and the lateral view between the tip of the screw and the center of the femur head. This summation should be less than 25 millimeter in order to achieve stable fixation and decrease the risk of failure. Usually in these devices, 2 screws are adequate for fixation. Uh, this is a randomized controlled trial on 1,000 patients in AO classification A1, 2, and 3 intertrochanteric fracture, showing that no difference between sliding hip screw versus cephalomedullary nail and comparable operative time and length of stay and cut out and non-union, and all the complications rate and percentage were close to each other. شباب المقيمين, can anybody criticize this what we just said about this article? شباب.
حلو السؤال دكتور محمد.
مين معي؟
أنا ياس محمد.
هلا دكتور ياس، هلا بعدين، كيف حالك؟
الله يسلمك.
هسه صراحة أنا حكيت عن هاي الستدي اللي كانت يعني موجودة في نطاق إنه using the DHS and using the PFN، وحكوا إنه 1000 مريض A1 A2 and A3 intertrochanteric fracture لقوا إنه ما في difference between the sliding hip screw and the cephalomedullary nail. Can anybody criticize يعني هذا الكلام موجود بهاي الستدي؟ يعني أنا intentionally بصراحة يعني حطيت هذه الارتيكل يعني أوكي. In order just to not spend too much time, you notice that the A2 and A3, which is the unstable part, are included in this article, okay? وحكوا انه ما في فرق بين الدي اتش اس والميدالرينيل. We should go with caution regarding the literature. Okay, A3 for example is the reverse oblique fracture. There is a wide acceptance and wise agreement إنه هذا الفراكشر should be managed with an intramedullary device. بس لاحظوا it was included in this article وحكوا إنه برضه ما في فرق بين الدي اتش اس وما في فرق بين السفالوميدالري nail. So be cautious, okay, because the proportion of A3 fracture in this 1,000 okay patients okay might be just little, and the author came with this conclusion which might not be accurate okay for this specific type of fracture. So أنا بس يعني عشان نكون just to mention إنه be careful when you are dealing with the literature. Not everything is taken as a solid as it looks. Okay. حكينا عن stable intertrochanteric fractures، حكينا we can use either a DHS أو cephalomedullary nail. Okay. الآن we are shifting to the unstable intertrochanteric hip fractures. Should we use a DHS or an intramedullary implant? According to the American Academy of Orthopedic Surgeons, patient with unstable intertrochanteric fracture should be treated with a cephalomedullary device, and the strength of recommendation is strong. While in the NICE criteria, the National Institute for Health and Care Excellence use extramedullary implants such as sliding hip screw in preference to an intramedullary nail in patients with trochanteric fractures above and including the lesser troch, and they restricted this exclusion to AO classification types A1 and A2. So there's an article around 206 patients, stable and unstable intertrochanteric fracture, comparing the DHS and the cephalomedullary nail in both stable and unstable fractures. There was no difference in reoperation, but more fracture shortening with sliding hip screw. Active functional patients have a better outcome with an intramedullary nail. So we a little bit, or there is, let's say, tendency to go with intramedullary fixation, cephalomedullary nail in this subset of patient, this group of patient. Again, another study, meta-analysis of 18 randomized controlled trial, including around 2,400 patients with unstable fractures. There was no difference in cutout or non-union mortality, reoperation, or blood loss, but cephalomedullary nail have a lower rate of implant failure. We talked about stable and unstable. Now, another entity of unstable intertrochanteric fractures is the reverse oblique intertrochanteric hip fracture. It is unstable fracture. This fracture is very important to recognize because sliding hip screw, DHS, frequently fail, and these fractures should be treated with a cephalomedullary implant. the American Academy for Orthopedic Surgeons have a strong recommendation of using cephalomedullary device in reverse oblique fractures and subtrochanteric fractures. Because as you can see in this X-ray, okay, there is a shearing on the between the two sides of the fracture line. This transferred the stress to the plate, and the stress is transferred to the screw bone interface, causing failure of all of the screws. This is supported by the literature, with the 47 reverse obliquity fractures studied, 32% failed or did not heal. 56% of those of these failures of sliding hip screws, and 17% failure of cephalomedullary nail. Another subset is the subtrochanteric hip fracture. Again, intramedullary versus extramedullary implant. There's an agreement to use, strong evidence to use a cephalomedullary device in subtrochanteric fracture. Again, in those subtrochanteric fracture, the cephalomedullary nail has fewer revision rate fixation failures and non-union. Intermedullary fixation, when it is strongly recommended in reverse oblique fracture pattern, subtrochanteric fractures, comminuted fractures with loss of medial or lateral buttress. We'll not talk about too much details regarding the intertrochanteric fracture fixation, but just to have just to highlight an important points regarding fixation with cephalomedullary nail. The nail is not a reduction device. You have to reduce the fracture first. Don't hesitate to go for open or mini invasive techniques if necessary to achieve the reduction. Be careful about lateralizing the entry. Don't trim away the trochanter. Whenever you are in doubt, go for a little bit more medial entry point. You will end up with favorable outcome when you go medial rather than going lateral. And while doing reaming, also medialize during the reaming process. When we are using cephalomedullary nail, should we go for long or short nails? Usually, whenever the fracture is within 3 to 4 centimeter from the lesser trochanter, it can be safely managed with short nails. Early nail designs lead to large stress riser at the short nail distal screws, okay, and cause stress riser and fracture. But now recent designs are immune against this. Advantage of long nails is that it protects the bone. But disadvantage or challenge is the mismatch between the radius of the curvature. This can lead to a distal anterior cortical perforation, and fractures also can happen with long nails even, but just at a different location. Whenever you are using make sure to have the contralateral side well fixed in order to avoid rotation of the pelvis and obscuring or hiding of the entry point. Now, reduction of unstable, usually the stable intertrochanteric fractures are easy to reduce just with simple traction, internal rotation, achieve the reduction. But in unstable intertrochanteric fracture, we are faced with many challenges. The first one is the shortening of the shaft. Another thing is usually the kind of impaction at the medial side. And the third thing is that the head neck piece usually falls posteriorly. Why? Because the tension side in the intertrochanteric fracture is the anterior side. And many times there is a posterior comminution, and this will create a space for the neck head piece to collapse posteriorly. Just in rapid description and rapid clarification, how to manage this. As you can see in the top image in the lateral view, okay, you can see that the neck headpiece collapsed posteriorly into the posteriorly comminuted, okay, area, along with the impaction on the AP view. How can we go and correct this? Okay, we can go with a simple, small anterior incision, anterolateral incision, and going into a safe dissection using a blunt lever, okay, and go and do levering at the fracture site in order to achieve the reduction and elevate the posteriorly collapsed head neck piece. At the same time, we should also manage the impaction, okay, by doing lateral traction, use whatever you want, okay, either a towel, bone hook, bone holding clamp, whatever you want in order to achieve this, and you will end up with a nice reduction, as you can see in these X-rays. Please notice the nicely reduced anterior cortex and the defect posteriorly caused by the posterior-medial comminution. The bone hook at the shaft that allowed for the disimpaction at the fracture site. This is a calcium phosphate augmentation, okay? Usually, actually, there is no evidence, no specific convince regarding the advantage of this method, and there is some case reports regarding the extrusion of the cement, the material into the joint, ending up with let's say a bad sequelae complications. So this is you can see an extrusion of the material of the bone cement material or cement augmentation into the joint, as you can see at the right side. The other subset of geriatric hip fracture is what we know as intracapsular neck-of-femur fractures. Okay. Now, for stable femoral neck fractures, the valgus impacted, non-displaced fracture, we have a variety of options for fixation according to the American Academy of Orthopedic Surgery. We can go for hemarthroplasty, internal fixation, or non-surgical care may be considered, and the surgeon is less limited by the options. When I have unstable femoral neck fracture, displaced or comminuted, but fragmentary, arthroplasty is recommended, and there is a strong recommendation. Arthroplasty is recommended over fixation. When I go for arthroplasty, should I go for a total arthroplasty or a hemiarthroplasty? There is a moderate evidence by the American Academy that in properly selected patient with displaced, unstable femoral neck fracture, there may be functional benefit to total hip arthroplasty over hemiarthroplasty, but this at the risk of increasing complications. So when I go for hemiarthroplasty, should I go for a unipolar or a bipolar hemiarthroplasty? Again, according to the American Academy guidelines, in patients with unstable femoral neck fracture, unipolar or bipolar hemiarthroplasty are equally beneficial, and strength of recommendation is moderate. Should I use cemented or cementless femoral stems? Again, a strong recommendation is to go for a cemented. To use a cemented femoral stem is recommended. And regarding the surgical approach for those patients, the evidence does not show favored surgical approach in a moderate strength recommendation. Pain actually comes after the fracture, after the surgery. Pain is a disease, okay? Why is treating pain is important? This is because pain will cause disturbance of sleep, will cause delirium, will cause depression, and it has a pathological effect because it affects the response to the treatment of the different comorbidities. And inadequately managed pain will cause delayed ambulation, cardiovascular and pulmonary complications, delayed transition to less intensive care settings, and aggravation of comorbidities and aggravation of mortality risk. What's the timing for pain management? Preoperatively, intraoperatively, and postoperatively at all times. Types may be pharmacological or non-pharmacological, and there is a recommendation to have a multimodal pain management, combined approach that disrupts pain in more than one component of the pain pathway. Again, زي ما حكينا انه Pain affects different organs, okay, in different ways. Regarding the heart, it will increase the heart rate, it will increase the blood pressure and the myocardial oxygen demand. Regarding the lungs, it will increase the respiratory rate, decrease the vital capacity, and this will increase the risk of atelectasis. Again, on the brain, it will decrease the mental status and exacerbate, as we said, the other conditions. At the other side, excellent pain control will improve the cardiac physiology, the pulmonary physiology, will provide the patient will be delivered a proper nursing care and improved physiotherapy, rehabilitation, and earlier immobilization, and less loss of muscle strength, decrease the risk of thrombosis, decrease the risk of decubitus ulcers, and short length of stay. We should hit the pain with strong analgesics, either IV or oral. Morphine is the gold standard. Hydromorphone is another option, which is a cleaner with less metabolites, 2 to 8 times the morphine potency, where 7 milligram of morphine can be, we can use instead of that 1 milligram of hydromorphone. Same efficacy, but we should be cautious in patients with renal disease. It's best to avoid. Oral oxycodone, limited or no metabolites, inexpensive, familiar, readily available, and many preparations to choose from, but there is risk of addiction. Opioids to avoid, meperidine, bethidine, because the active metabolites of bethidine can cause delirium. Propexifene, codeine. The problem with the codeine is that it must be metabolized, and some people cannot metabolize in order to get effect, and more nausea and constipation than other pain medications. Tramadol may be associated with higher risk of seizures and cannot be used in combination with true opioids. Pain control strategy, as we said, we should hit the pain pathways in the whole, in more than, let's say, one pathway. Routinely use acetaminophen around the clock. Relative maximum dose is 2 to 3 gram daily. Absolute maximum is 4 gram daily. Morphine 2 to 4 milligram IV every 1 to 2 hours PRN, and oxycodone 2.5 to 5 milligram post-operatively every 2 to 3 hours. No combination of drugs, weak opioids, and partial agonists, and avoid the complicated regimens. What if the patient is already on chronic opioid use? We can increase the usual dose by 30 to 50%. If the pain is still there, we can go for a rescue dose, 10% to 30% of the daily dose, and recalculate doses every 24 hours. Total daily dose of opioid is divided, into doses, 2 to 4 doses. And important thing of pain management is the nerve blocks. Many guidelines worldwide, and many recommendations recommend having a nerve block even at the emergency, immediately after the fracture, with iliac fascia block and other methods of regional block. Now, what is nerve block? We are hitting the nerve impulses from a region of the body. We have either peripheral or neuraxial nerve block, and the advantage of regional anesthesia is that it is vastly superior pain control, and it eliminates the need for opioid use in the first 24 hours postoperatively, and it provides preemptive analgesia even before the pain cascade or pain process starts, especially when this is done in the theater. Low risk of nausea and vomiting, minimal central nervous system effect, decreased rate of postoperative delirium, earlier and better physical therapy. Patient satisfaction is improved and lowers the length of stay. Now, in the hip fracture, we have what's known as femoral obturator and lateral femoral cutaneous nerve, 3 nerves, 3 in 1. Lumbar plexus or neuraxial. Can be done, as we said, preoperatively in the emergency department. The American Academy regard to multimodal analgesia, there is a strong recommendation to incorporate a preoperative nerve block to treat pain after hip fracture. The NICE criteria regarding pain management they advise to offer paracetamol every 6 hours, pre and post-operatively, unless contraindicated, and offer additional opioids if paracetamol alone does not provide sufficient post-operative pain relief, and they not recommending using non-steroidal anti-inflammatory drugs. Now, regarding Rivaline, acetaminophen, after major surgery, in some studies, it provides a morphine-sparing effect of 20%. The multimodal pain regimen after major surgery with acetaminophen, non-steroidal, or COX-2 inhibitors given with morphine after surgery, there was a decrease in morphine consumption by 15 to 55%. NSAID also reduced nausea and vomiting and sedation, but increased the risk of severe bleeding. Increase the risk of severe bleeding, as we said. Regarding the gabapentin and pregabalin have a 50% reduction in 24 hours preoperative morphine requirement. And we'll talk after a while why everybody is talking about decrease the need for opioids. This is because opioids are not safe medications. It has its own side effects, its own complications, okay? Another thing, another method of pain control, which is periarticular injections, okay? It's provide a less need for opioid. Again, peripheral nerve blocks, according to this review, reduces pain on movement within 30 minutes after block placement. And there is a moderate quality evidence for decreased risk of pneumonia, reduced time to first mobilization, and reduced cost of analgesic regimen. Again, with fascia iliac block, it has a significant, it has, let's say, positive effect, okay, regarding the use of another systemic pain medications, okay. The use of systemic pain medication was decreased in, little bit decreased in patient with a fascia iliac block. Now, what are the problems with opioids? Baseline opioid use increase the risk of fracture. Meta-analysis of 8 cohort studies show that use of opioids increase the risk of fracture, even risk for fracture. You can notice that from this meta-analysis that use of opioid increase the risk of falls, increase the risk of fall-associated injury, and increase the risk of fracture. So, pain management, limited evidence, but scheduled paracetamol with or without periarticular and regional blocks should be considered to reduce opioid consumption in this population. Chronic opioid use should be discouraged because of it is bad side effects. Delirium, finally. Delirium, what is delirium? Delirium can be defined as a state of acute brain failure, acute confusional states. And it's associated with poor outcome. The problem with delirium is that it's not recognized usually, not evaluated, not managed, not taken seriously, not managed in a proper way. Onset of delirium is acute and lasts for hours to days. There is reduced clarity of patient awareness. There is impaired ability of the patient to focus, to sustain attention, to shift attention. Those patients may be agitated, irritable, emotionally labile or drowsy, quiet and withdrawn. It's not always have a hyper face. Sometimes it has hypo face, along with fluctuation in level of consciousness. And delirium, what is specific for delirium is that it cannot be explained by the patient pre-existing, established or evolving dementia. So this is an acute event. So delirium begins with baseline vulnerability, patient with dementia, with old age, with polypharmacy, okay? Along with fracture, there is a vulnerability to delirium. As you can see, there is two subtypes, motor subtypes, hyperactive or hypoactive. The hyperactive type, there is a restless agitation. In the hypoactive, there is somnolence, and there is a mixed phase which is combination of these presentations and in fluctuating course. Now, what is the fate? 75% of patients recover over days, 2 weeks. 25% of patients have persistent delirium. If you want to look to the brain as a CPU, okay, so we should be careful about the input devices. We should be careful about the input from the eyes, the input from the ears. Okay, so make sure that if your patient is using glasses or he used to use a hearing aid, he is using that. Okay, after admission, be careful about the causes of delirium that can be summarized. Okay, in these categories. D stand for drugs, opioid, anticholinergics such as antihistamines, sedatives, steroids, benzodiazepines, chemotherapy, immune therapy, other antibiotics. Eyes and ears, poor vision and hearing, isolation, low flow state, hypoxia, MI, heart failure, COPD, and shock, infections, retentions of urine or stool, restraints, okay, restraining the patient to the bed, okay, also causes psychological stress on those patients, might precipitate delirium. Intracranial issues such as METs, seizures, subdural, CVA, hypertensive encephalopathy, issues with hydration and nutrition, underhydration, undernutrition, sleep deprivation, all of these can precipitate delirium. Metabolic disorders, electrolyte disturbances, and vitamin deficiencies, and toxins, okay, all of these again can precipitate delirium. To differentiate between delirium and dementia. Delirium is acute. Dementia is gradual. Delirium is fluctuating in course. Dementia is progressive. Delirium comes over days to weeks, while dementia months to years. And consciousness is altered in delirium, while it's clear in dementia. And regarding the attention is impaired in delirium, but in dementia it's normal unless severe dementia there. Psychomotor changes increase or decrease in delirium, as we said, hyper or hypoactive, but psychomotor changes in dementia as often normal, and usually delirium in 75%, as we said, is reversible, while dementia is rarely reversible. The NICE criteria minimize the risk of delirium and maximize independence by active looking for cognitive impairment when patient first present with hip fracture, and in a timely manner, regularly reassess the patient to identify delirium that may arise during the admission, offering individualized care in line with the NICE guidelines on delirium. Keep in mind that the eyes don't see what the mind doesn't know. Delirium guidelines within 24 hours of admission assess people at risk for clinical factors contributing to delirium, such as cognitive impairment, disorientation, dehydration, hypoxia, infection, immobility, pain, medication review, poor nutrition, sensory impairment. When we are managing delirium, how to manage delirium? There is different ways to manage delirium. Okay, medical, pharmacological, and non-pharmacological way. The primary prevention: avoid benzodiazepines. It can precipitate delirium. The non-pharmacological treatment, sensory, include the sensory input, reorientation. Always ask the family, whoever is combining the patient, to keep talking to the patient, to keep orienting the patient regarding the time, regarding the persons that came to the patient, okay, regarding the events, okay. You use the eyeglasses, using the hearing aids, okay, provide cognitive stimulation activities, okay, ask the family to keep asking and keep talking to the patient, okay. Timely removal of catheters and restraints and air immobilization. Regarding the pharmacological treatment, stop any offending medications and consider any antipsychotics such as haloperidol and quetiapine. What are the consequences of delirium or after hip fracture? Sorry, causes of delirium after hip fracture. Delirium most likely to happen after the surgery. In 54% of patients, it happens after the surgery. the most frequent causes, as we said, sensory and environmental infection, drug use, fluid and electrolyte disturbances. Does intraoperative sedation cause delirium or affect delirium? Limiting intraoperative sedation did not appear to decrease delirium. This study found that geriatric consult service versus the usual care in those receiving geriatric consult services have less delirium. Okay, but what kind of recommendations those geriatric health care provider did for those patients? They made an average 10 recommendations per patient. Those including transfusion for hematocrit less than 30 and 92%, and discontinuing benzodiazepines and anticholinergics in 68%, power regimens in 68%, DC urinary catheter in 71%, treat fluid overload or dehydration in 48%. Now, regarding the rehabilitation protocol, should we go for immediate full weight bearing? If this is possible, we should go for that. But the recommendation of the American Academy is that after surgical treatment of hip fracture, immediate evidence on immediate full weight bearing is limited. Okay, so you can manage your patient with partial weight bearing or as tolerated. Okay, there is no strict evidence on this, but it's important to know that quality of rehabilitation in the early post-operative period might have influenced the outcome. What kind of rehabilitation? Progressive resistance training, progressive balance and gait training, supported treadmill gait training, double task training, and activities of daily living training. Post-operative antibiotics, I didn't find any specific recommendations by the American Academy or the NICE criteria guidelines. Okay, there are some studies talking about if the patient has an obvious bacteriuria, management with antibiotic might cause decrease in early deep surgical site infection with proximal femur fractures when the patient is received antibiotics for 5 days. Another study on let's say significant number of patients, okay, found that there is no statistical relationship between surgical site infection with a single dose versus 3 doses of antibiotic in patients undergoing hip surgery. Post-operative management, DVT prophylaxis, start at post-operative day 1 and for 4 weeks. Delirium prevention, osteoporosis management, pain control, managed to get the fully early removed, okay, and straight catheter if there is retention. Thank you. This is a very extensive subject. I trying to just highlight the points I found important to take care of. And thank you, everybody.
دكتور محمد،
دكتور ياس،
الله يعطيك العافية يا باشا.
عافاك الله. أهلا وسهلا يا سيدي.
إذا بتسمح لي بالمداخلة البسيطة لو سمحت.
أهلا وسهلا، تفضل.
الله يعطيك العافية دكتور محمد. الصراحة يعني محاضرة جميلة جدا وأنا يعني بشكرك عليها. يعني موضوع الجيرياتريكس تروما، الجيرياتريك فراكتشرز، يعني الشباب المقيمين قاعدين بيشوفوا كيف موضوع الجيرياتريك فراكتشر اللي انت قاعد بتشوفه بالطوارئ وبتدخل على القسم اون ديلي بيسز مريض او 2 على الاقل باليوم، سواء كان هيب فراكتشرز او جيرياتريك فراكتشر، سواء هيب، ديستال فيمر، ريست، وات ايفر. فيو كان سي هاو ماتش topics hidden behind this patient. موضوع الجيرياتريكس معقد للغايه من ناحيه زي ما حكى الدكتور محمد، من ناحيه البري اوبراتيف، انترا اوبراتيف، وبوست اوبراتيف تريتمنت، بوست اوبراتيف مانجمنت، كومبليكيشنز. انا كنت بدي اسال صراحه، واحنا يعني خلينا نقول من 4-5 سنوات. السؤال لك دكتور محمد لو سمحت. كيف صار عندنا الابروتش بالجيرياتريكس هيب فراكتشرز او بالاوستيوبروتيك فراكتشرز بالخدمات الطبيه عندنا بمركز فرح خلال الاربع خمس سنوات يعني اللي راحوا؟ هل في اي تغيير على البروتوكول؟ هل في اي تغيير على الابروتش للمرضى؟ هل في الاهتمام اللي احنا بنطمح له؟ لانه اذا بتطلع على الجيرياتريك سبيشاليتي، في بالعالم شيء اسمه جيرياتريك سبيشالست، يعني اطباء خاصين بس بهذا الايج جروب اوف بيبل، لانه ما حدا بوصل منطق يعني هذا الايج اوف اللي عنده a lot of comorbidities heart kidneys lungs، وبكون عنده يعني a lot of complications to be happened with the fractures. فإذا بتقدر تعطينا، هل في عنا أي شيء specific approach بهذول المرضى؟
ثانك يو دكتور ياس. بصراحة هسه those patients بصراحة يعني ال changes that to be made they are very extensive changes started at the emergency and ending up at the discharge of the patient.
صحيح.
Um, yes, regarding بصراحة recently I found that many doctors are dealing with the issue of dehydration. Okay, but I think this still on an individualized base. Okay, يعني if you want to improve any issue, number one is increasing the awareness about this issue. Okay, so I think we have increasing awareness about the how يعني fragile are those patients, how dehydrated are those patients. Okay, فهذا this is number one. I think يعني many of our يعني respectful residents giving the patient IV fluid in the emergency, this is highly respectful. Another thing بصراحة I found إنه we are trying to shift every now and then, trying to shift analgesia from tramadol to morphine. Okay, I think this is a good advantage. Another thing is with pain management is that we are starting practicing the issue of regional anesthesia. I found many patients are receiving blocks. Okay, maybe little sometimes limited. Okay, because of the pain service, pain killing service provider. Okay, regarding the regional anesthesia, this is relatively a new era for the anesthesia. Okay, and a new area of practice. But I think يعني ممكن هذا الشيء ببداية البراكتس تبعنا ما كنا نشوفه انه حدا they go and do regional anesthesia او blocks, which is an advantage. Every now and then, as I said, okay, on an individualized let's say يعني يعني effort
بس
basis, we discuss some patients, okay, issues with the anesthesia. Okay, and by that بصراحة احنا skipping يعني some consults, some يعني unnecessary administrative work. Okay, اللي ممكن will delay the surgery, will reflect it back على ال poor outcome. Another thing is موضوع السيرجري. يعني كوني انا حاليا بالادفانس تروما تيم، يعني احنا بنحاول الجرياتريك هيب فراكتشرز كلهم هذول to be given priority on the operation list. Okay, يعني sometimes you find the patient that admitted on Sunday and operated on maybe Monday, Tuesday. Okay, so يعني as soon as possible. To be honest, still there are some challenges. Okay, we're still doing echo and cardiac consult in a regular way. Okay, but as we said, just we are trying to lighting a blind spot in this area. Maybe the issue of dementia, we are dealing with that to a limited way. Maybe the issue of blood pressure medication. Okay, we don't have the courage enough to stop the blood pressure medications. Okay, in a patient with optimized blood pressure. طبعا احنا بنحكي عنا يعني we start encouraging يعني our practitioners to go with discontinue the Follies, okay, in an early manner, insisting, okay, on the rehabilitations, to have rounds with us بصراحة يعني, and to go with an early rehabilitation protocols. Many times we are insisting على the issue of the malnutrition, okay, of the patients. We offered many patients a high protein diet, ensure milk, okay. and we look for the patient as يعني as a thorough. Okay, إنه this patient has metabolic activity and have physiological activity that should be optimized يعني as soon as possible. Um, I think the reduction techniques are also from surgical wise, okay, are being improved. The AO geriatric course, okay, geriatric hip fracture course was held, I think, 2 times, okay, uh, in the Royal Medical Services, which is again an advantage of increasing the awareness. Uh, I think يعني I think we are achieving progress. We are يعني eagering and hungry to go for a more and more positive progress إن شاء الله.
الله يعطيك العافية دكتور محمد، وصلت التوضيح وشكرا لك. وبالعكس احنا دائما we are always looking forward to improve our services to our patient ونطلع دائما ب the best outcome. زي ما صار في تروما تيم بالمدينة الحسين الطبية والأمور قاعدة بتتنظم أكثر. hopefully this age group population which who are very important صراحة in our society إنه to take also priority to have a geriatric team. لأنه زي ما أنت تفضلت يعني أنت بالمحاضرة as a surgeon your job about 1.5 hour بالعملية كلها، بس what goes beyond the surgery is a lot صراحة. فمشكور دكتور محمد، الله يعطيك العافية على التوضيح وعلى المحاضرة الجميلة، وآسف على المداخلة والإطالة.
كل الشكر يا سيدي، بالعكس you are very welcome. You are just يعني providing us with a very helpful بصراحة يعني notifications و very يعني helpful notes. Thank you دكتور إياس.
العفو سيدي.
الله يعطيك العافية دكتور محمد، محاضرة رائعة صراحة.
عافاك الله دكتور ناصر، حياك الله يا سيدي.
شباب أي سؤال، أي مداخلة؟
الله يعطيك العافية جميعا.
الله
عافاك الله
يعافيك
دكتور محمد، أهلا.
بصراحة دكتور محمد محاضرة أكثر من رائعة وموضوع كثير مهم. بس أنا بدي هيك أضيف كم شغلة. موضوع الجيرياتريك مانجمنت يعني صار فيه بروتوكول عالمي، يا ريت إحنا كخدمات طبية نشتغل على هذا الموضوع ونعممه بكل مستشفيات الجيش. الشغلة الثانية أنه برضو المانجمنت اوف جيرياتريك هيب فراكتشرز هي ما بتوقف الوقت اللي بيطلع فيه المريض من المستشفى. برضه لازم نشتغل على العوامل اللي بالبيت اللي خلت هذا المريض ينكسر. فالمانجمنت بتكمل to prevent the secondary hit لهذا البيشنت. فلازم نركز على هذا الموضوع، نفهم شو السوشيال هيستوري للمريض، ونحاول قد ما نقدر انه نمنع هذا الشيء يصير مره ثانيه للمريض. بس انا في عندي مداخله، يا ريت يعني مسج لكل الشباب. هذا الموضوع كونه فيري كومن بالمستشفيات الطرفيه، يا ريت يعني نشتغل على سيمينار او نعمل محاضره عشان نزيد الاويرنس لمرتبات المستشفى، لانه هذا تعرفوا الجيرياتريك تيم هو احنا بارت منه كاطباء عظام. فعشان نزيد الوعي بالمرتب، تمريض، فيزيوثيرابيست، سوشيال وركرز، التغذيه، لازم يكون في محاضره عن الجيرياتريك هيب فراكتشرز بكل مستشفيات الجيش. فيا ريت شبابنا المقيمين من خلال البرنامج العلمي اللي بنعمل بكل المستشفيات. انا يعني اشتغلت على هذا الموضوع بالزرقاء وقبل هيك بالمفرق، فيا ريت انه الكل نرجع نزيد الوعي للمرتب بهذا الموضوع، لانه بصراحه كومن بيشنتس بنشوفهم كثير، يعني ما في اسبوع الا بدخل 3 4 مرضى فيه. فهي المسج يعني يا ريت انه شبابنا عن طريق رؤساء الاختصاص بالمستشفيات الطرفيه يشتغلوا على هذا الموضوع، يعملوا محاضرات توعويه لمرتبات المستشفيات.
شكرا دكتور محمد. اكيد بصراحه يعني هو بالاخير كو مانجمنت ذيس تيم يعني ببلش بالامرجنسي، ببلش بالميديكال ببلش بالانستيزيا. يعني ذيس كو مانجمنت، هذا مش بس جاست ريسبونسبيلتي لاطباء العظام الاورثوبيديك سيرجنز. هذول فراجايل بيشنت، الجنرال كونديشن تبعهم تبع الجنرال فيسيولوجي لذير بوديز is that they are fragile patients. They are يعني خلينا نقول full of يعني weakness points. اوكي، فثانك يو طبعا. اكيد يعني هذا شيء يعني essential اساسي يعني to keep in mind. Thank you again.
بس كمان في شغله تكنيكال، يا ريت احنا يعني كلجنه علميه نوصلها to our seniors. اللي هو موضوع بتعرفوا انه الجيرياتريك هيب فراكشرز كونه كومن فراكشر بالبريفري في كثير معاناه وديلي اوف تايم للسيرجري، هو بس من وراء انه هو البي اف ان موجود مع شركه واحده. فهذا هاي الشغله التكنيكال قاعد المريض بقعد بالمستشفى اسبوع 10 ايام لحتى ينشغل، فهو خلال 48 اورز بكون جاهز للعمليه، بس ما في شركه تيجي تغطي. فما بعرف هاي الاشيو كخدمات يا ريت نشتغل عليها ونعدلها، وما بعرف يعني شو الآلية. بس بصراحة بالبريفري هذا موضوع كارثة، كثير مرضى بوست اوب بدخلوا اي سي يو خلال يومين بكونوا يعني بصراحة المورتاليتي ريت فيري هاي من وراء الديلي. فما بعرف احنا ما بعرف شو في آلية نعدل هذا الاشي او تو تشينج ذيس براكتس، انه العطاءات تصير تنزل على اكثر من شركة. والله يا محمد انت عارف يعني الموضوع هذا كثير كروشيال
صحيح
وكوست
اكيد.
وايز يعني.
واعتقد انه هاي النقطه تمت اثارتها يعني، وفي شغل يعني جاري على الموضوع، انه يكون يعني امكانيه انه الحالات اللي بتم يعني علاجها في نفس الوقت، وتوفر العدد، توفر الريسورسز، تكون يعني في اسرع ما يمكن. اعتقد هاي النقطه طرحت يعني للموضوع النقاش، ان شاء الله يعني تاخذ بعين الاعتبار كمان بالايام الجايه والعطاءات الجايه.
ان شاء الله يا ريت يا رب. الله يعطيك الف عافية، محاضرة رائعة للأمانة.
عافاك الله، كل الشكر يا صديقي.
طيب ما بعرف إذا ما ضل مداخلات عند الشباب، ما ضل أي أسئلة. منتهي لقائنا اليوم، وهذا الأسبوع ما عملنا كيس ديسكشن. راح أجلنا الأسبوع الجاي بترتيبات معينة. الأسبوع الجاي في عندنا محاضرتنا موعدها، وكيس ديسكشن إن شاء الله راح يكون about pelvic fractures. بالمدينة راح يكون مع دكتور فادي الرسام، وباقي المستشفيات كل المستشفى بالتنسيق مع أخصائيين ورئيس قسم. دكتور محمد الله يعطيك العافية. دكتور ياس، دكتور محمد الله يعطيكم العافية مداخلاتكم.
الله يعافيك.
الله
يعطيك
يلتقي.
العافيه، شكرا دكتور ناصر، جزاك خير على جهودك.
الله يعافيك دكتور محمد، الله يسلمك. ونلتقيكم إن شاء الله الأسبوع القادم. السلام عليكم ورحمة الله.
السلام ورحمه الله وبركاته.